To the Health for the World International Grand Rounds. It's my honor to welcome our Grand Round speaker today, Dr. Tina Poussaint. Dr. Tina Poussaint is Professor of Radiology at Harvard Medical School and is the Lionel Well Young Chair in Radiology at Boston Children's Hospital, where she also serves as an attending neuroradiologist. She received her MD with honors from Yale University School of Medicine. After an internship in pediatrics at Yale New Haven Hospital, she completed her residency training in diagnostic radiology and fellowship in neuroradiology at Massachusetts General Hospital. After serving on the neuroradiology faculty at MGH, she joined the faculty at Boston Children's Hospital. Dr. Poussaint also serves as Director of Neuro-Oncological Imaging and Director of Pediatric Neuroradiology Fellowship. She is a fellow of American College of Radiology and has served in several professional organizations, including the ASNR, RSNA, and SPR. She is also a past president and gold medal recipient of the American Society of Pediatric Neuroradiology. She is the past president of American Society of Neuroradiology. She is the chair of Institutional Review Board of Boston Children's Hospital. She's a world-renowned neuroradiology educator and, above all, a very nice human being. I worked with her when I was training at Boston Children's Hospital. It's my honor to welcome Dr. Tina Poussaint today for such an important topic of pediatric brain tumor imaging in the molecular era. Thank you so much, Tina, for doing this for us.
Thank you. Well, it's really my pleasure and honor to speak to you today for the Health for the World International Ground Rounds. This program is so important for really extending our reach throughout the world of radiology. So I very much thank Dr. Rahani for this wonderful honor. And I'll be speaking today, as she mentioned, on pediatric brain tumor imaging in the molecular era. My lecture will discuss imaging findings in a subgroup of pediatric brain tumors. We'll talk about different imaging approaches, and I'll also include the new WHO 2021 classification, which has put forth advances in knowledge about molecular classification of these tumors. My disclosures are that I am principal investigator for the Pediatric Brain Tumor Consortium Neuroimaging Center. So pediatric brain tumors are a leading cause of death from solid tumors. And if you look at this particular graph, you can see that in 2022, there were about an estimated 3,920 new cases within the United States in children less than the age of 14. And in terms of this group, leukemias, lymphomas, and other types of tumors follow these types of tumors. So our goal of imaging is to really define and diagnose the extent of disease, to guide treatment planning, to look at the shape and volumetrics of the tumor, and to try to quantitate this tumor growth and volume over time. And with our imaging techniques that we have available, we can work on tissue characterization with physiological specificity, and this is used in particular in clinical trials to monitor response. Now, what are the imaging techniques that we have available? Well, you're all probably familiar with diffusion-weighted imaging, which really can give us an assessment of the tumor cellularity. Diffusion tensor imaging can look at the white matter fiber tracts, and then with perfusion techniques, including dynamic contrast enhanced MR, arterial spin labeling, and T1 permeability, we can look at perfusion vascularity and angiogenesis. Also, we can look at metabolism with MR spectroscopy and some of the biochemical pathways with the molecular imaging, PET, and the eloquent cortex with functional MR, magnetoencephalography, and magnetic source imaging. So pediatric tumors in general are really a heterogeneous group of tumors. And in particular, compared to adults, one has a variety of tumors that we don't see in adults. And so it's a really unique group of brain tumors. And it's really important that understanding these heterogeneous tumor types really requires different imaging protocols for optimal assessment when we're trying to see how these tumors respond to therapy. So in 2013, this article was published, which was a report from the Response Assessment and Pediatric Neuro-Oncology Working Group that came together to try to actually discuss the issues that would be unique with pediatric neuro-oncology. And in particular, most hospitals have very small numbers of these types of tumors. So it's very important to actually involve these children in multi-center trials. And then some of the criteria that have been used, particularly with adults, such as enhancement. When you look at actually pediatric brain tumors, enhancement can be variable, and it may not always represent the tumor burden. Also, if over time, sometimes a decrease in the tumor size does not always correlate with survival. And then, of course, we're familiar with the fact that when we look at these studies, there can be considerable inter-observer variability. So after this article, a series of articles came out from the same group, the Response Assessment in Pediatric Neuro-Oncology, to look at other tumor types. And I won't be able to talk about these today, but only point them out to you as resources that are available when you're looking at the response assessment in various tumor types. For example, there's one on medulloblastoma and the leptomeningeal seeding tumors, pediatric low-grade glioma, pediatric high-grade glioma, and the diffuse intrinsic pontine glioma. And there are some new subgroups that have been established for ependymoma and craniopharyngioma, and those have just actually been released as well or in press. So you can look at those. So in terms of the response assessment in craniopharyngioma and ependymoma, those came out just last year, and you can see the authors that were involved here. Now, I just want to point out that there was an article that we published in 2022 that really covers some of the changes with the 2021 World Health Organization classification of tumors of the CNS and what neuroradiologists and radiologists need to know about this classification. So let's talk a little bit about the WHO classification for the CNS tumors and how it differs from the previous. Now there are actually, this is an integrated diagnosis, which really stratifies patients for tumor treatment. The brain tumors are classified according to specific types and subtypes, and they're characterized by the molecular alterations with specific gene mutations and other epigenetic features that are really important for understanding the behavior of these tumors. The grading changed from 1 to 4. Instead of Roman, it's now Arabic numbers. And the histologic features are very relevant, including the mitotic activity, microvascular proliferation, etc. But in this classification, the molecular profiling is really a key feature, and we'll review these for some of the categories of disease. So now when we look at the first category, which is gliomas, glioneuronal tumors, and neuronal tumors, there are various categories. And in this talk, we'll be talking just about the pediatric categories. But there is, of course, one for the adults as well. So let's first talk about the pediatric low-grade gliomas. And these are important to know about because they're really the most common glioma in childhood. They are often seen at ages 0 to 9 years. They have a really good outcome when there's a complete resection of the tumor. And it's important to remember that syndromes such as neurofibromatosis type 1 and Noonan syndrome have an increased incidence of pediatric low-grade gliomas. Now, recently, there's been a big analysis of the molecular and clinical characteristics of these pediatric low-grade gliomas that was done in 2020. And it's been found that they can, of course, occur any place within the brain, more often seen, however, within the cerebral hemispheres and the diencephalon. And if you look at the drivers that are involved in terms of molecular drivers, they include the Ki-1549 BRAF fusion genetic marker, the BRAF V600E, and then neurofibromatosis type 1. But I just point out that there are actually several of these drivers that they've discovered. And so depending on what driver is involved with the low-grade glioma, it actually has an effect on the risk. So that, for example, depending on what the driver is, you can be characterized by having a low risk tumor, an intermediate risk, or high risk. And if you have one of the high risk or intermediate risks tumors, this affects the overall survival, with, of course, the high risk having a shorter overall survival. So it's just important to know that these drivers are actually incorporated in terms of the analysis and not just the histopathology. Now, there has been a proposed model for the pilocytic astrocytoma pathogenesis, and as true as in other pediatric brain tumors, it's thought that there's some sort of aberration in the normal development from the normal progenitor cell. So you'll have a susceptible progenitor cell that has a mutation. It can lead to the development of one of these tumors, and if there's no stromal support, these tumors can actually just shrink and become senescent. However, if there is sustained stromal support and genetic epigenetic alterations, this tumor can increase in size. But at this same point, if there's growth inhibition, the tumors can stop. But if there is continued stromal support and genetic epigenetic alterations, the tumor can grow. So this is one of the proposed models from researchers in the field in terms of looking at pilocytic astrocytomas. Now, these can be a variety of types of tumors, including the pilomyxoid astrocytoma, often associated with the diencephalic syndrome and in the suprasellar region. They can be associated with neurofibromatosis, particularly neurofibromatosis. There's an increased incidence of optic pathway tumors. And of course, within the posterior fossa, you can have, and in the supratentorium, the pilocytic astrocytoma, typically with a cyst and a solid component, but can also be solid. And then, of course, within the brainstem, they have the tictal gliomas. So there's a wide range of these types of tumors that can occur any place within the CNS. Now, these tumors actually have a really good survival, but they can have high morbidity if you can't resect the disease. And here's an example of a patient who has neurofibromatosis with an optic chiasmatic lesion, which is enhancing. And of course, if you resect this tumor, this is going to really compromise the visual capabilities of this child. And so there have been attempts to try to see, are there therapies that can be done that could actually help this group with the high morbidity, long survival. And so in terms of looking at the neural glial cell proliferation, it has been found that the mutations that have to do with the formation of these low-grade tumors include neurofibromin, which is associated with neurofibromatosis type 1, and then I mentioned the BRAF mutations. And of course, these pathways are a part of the RAS pathway. And if there are these aberrations, this leads to increased cell growth and tumor formation. So what people have been trying to do is to try to see if they can target this pathway with drugs that would inhibit this. So one of the ones that was used is solumetinib, which is a MEK inhibitor, and there are quite a few of these. And so in 2019, the first report was made of looking at children who had pediatric low-grade glioma and received this drug. And they found that if they had a certain mutation, the BRAF fusion mutation and neurofibromatosis type 1, these pediatric tumors had a really high response rate, with the neurofibromatosis children having a 40% response rate in this trial, and those with the fusion a 36% response rate. So let me show you an example. Here's a child who at baseline had this very large mass. It was within the suprasellar region growing up into the third ventricle. It showed some marked enhancement. It was also involving the optic chiasm, but extending and very extensive. It was thought this was really not going to be safe to resect, so this patient was put on 10 months of solumetinib. And you can see over time that there was a gradual shrinkage in size of the tumor, both on the T2 and on the gadolinium enhanced images. So we decided to actually look to see, aside from the standard features that were associated with this, which we say is decrease in tumor size and decrease in enhancement, are there other features that we can look at to understand what's happening within the milieu of this tumor? So In 2022, we presented this, published this paper where we looked at diffusion characteristics in the volume of the tumor to try to see if we could characterize the internal milieu of the tumor as it relates to diffusion. So at baseline, in a patient who had response to the therapy, if you look at the volume of the ADC values and create this histogram, after the therapy, there's a transient increase in these metrics. So possible increase in the mobility within the tumor due to early cell death. And then as the patient shrinks the tumor, this is followed by tissue consolidation. So this is something that we had found in this 6-year-old boy who had a response to the selumetinib, and we saw this in other responders in this trial. Now, when we looked and compared those that had neurofibromatosis type 1, who had optic pathway tumors, to those that did not, you can see that those with neurofibromatosis type 1 really had no change in terms of those diffusion values within the volume, but those that didn't had a gradual decrease over time with months of therapy. Now, this is really different, actually, from what you see in adults. In adult high-grade tumors, it was thought that, and this was what's published in 2007, you start with a solid tumor. It has increased cellularity, so it has low diffusion values within the volume. And then after you have treatment, there's a gradual increase because of necrosis and necrotic tumor of the water mobility within the volume of tumor and an increase in the ADC values. But in low-grade gliomas that are treated and that we look at these ADC values, they have actually much different trajectory, starting out with a lower ADC, and as the therapy increases, that ADC increases, and then as they actually respond, it actually compacts and goes down. So it shows you that there are differences in terms of high-grade adult tumors versus low-grade. Now, one of the big categories of disease, of course, associated with low-grade gliomas is the neurofibromatosis type 1. And of course, this is characterized by cafe au lait spots, skin neurofibromas, the Lisch nodules. And in young children, we often see that there's this pseudoarthrosis that occurs of the tibia. And of course, these patients can develop optic pathway tumors. And it's thought that the optic nerve axons secrete these chemokines that affect the microglia. And then through a feedback loop, there's actually growth factors that stimulate these neoplastic glia to form. And there are also neurotoxins that are also released by the microglia that affect the optic nerve axons and lead to the decrease in the vision that these patients have. So typically we see, as in this patient, enlargement of the optic nerves, enhancement along those optic nerves, expansion of the chiasm. And of course, other manifestations occur with these children, including plexiform neurofibromas that are often transspatial, any place within the body, neurofibromas along the exiting nerve roots of the spine and in the subcutaneous, the absence of the greater wing of the sphenoid with the pulsatile exophthalmos that can result. And then, of course, these children also get these areas of T2 prolongation, which occur within the cerebellar hemispheres, the pons, the thalami, and the basal ganglia. They start about age 3, increase in size and number, and then, interestingly enough, they actually go away after adolescence and are thought to represent regions of myelin vacuolization, and they usually don't enhance. Okay, let's talk about some of the other diffuse low-grade gliomas, and they're in these categories that occur in children. Now, one of the new categories in the new WHO classification is the polymorphous low-grade neuroepithelial tumor of the young. And this is a tumor that's similar to oligodendroglioma and that it often has calcification. It's seen in children and young adults, and they often present with seizures, often in the temporal lobe, as we see here, and we see calcification and occasionally cyst. So here we see this area of calcification. It's hyperintense on the T1 weighted images, and there's actually very little enhancement of this tumor. And this is a new categorization of this tumor called the polymorphous low-grade neuroepithelial tumor of the young. Now, this is another patient who had one of these lesions. We can see it in the subcortical white matter, and it's slightly hyperintense in the periphery on the FLAIR images and shows little or no enhancement. And these tumors will have positivity for a molecular target called CD34, and positivity also with the oligo2 and evidence of some fibrous material in the H&E scans, as well as very little cellularity and positivity for GFAP. Now, another of the low-grade tumors that you may encounter is this diffuse glioneuronal tumor with oligodendroglioma-like features. And this is a diffuse leptomeningeal disease primarily seen in children and adolescents. It has morphology similar to oligodendrogliomas and can be associated with BRAF fusions. And it's important to know about this because these children can have slow growth and morbidity from secondary hydrocephalus, and also it can be interpreted as other types of processes. And I'll show you an example. Here's an example of a child who had the diffuse leptomeningeal glioneuronal tumor. You can see when this patient actually presented, we see all these little areas of cyst formation within the leptomeninges of the brain parenchyma on the coronal and axial T2-weighted images. But there's significant leptomeningeal enhancement along the basilar cisterns and in the sylvian fissures that's characteristic of this diffuse leptomeningeal glioneuronal tumor. They don't always have these little cysts that are associated, but if they are just presenting with just the leptomeningeal enhancement, often these patients may be misdiagnosed as either having meningitis or some other kind of carcinomatous meningitis or a granulomatous process such as TB or sarcoid. But you should be aware that within that differential diagnosis is this low-grade entity, the diffuse leptomeningeal glioneuronal tumor. So here we see within the spine of this child many areas of cystic change, and then the extensive leptomeningeal enhancement affecting all of the surfaces. So what happens is these patients will present with this, and they often will have to be shunted because there is a disorder in terms of the circulation of the CSF. Even though they're low grade, this can cause, quite a bit of morbidity for these children. Now, another low-grade glioma that's been seen is the multinodular and vacuolating neuronal tumor. These are don't touch lesions. You may notice them as clusters of T2 hyperintensity. These are two different patients. One has this cluster of T2 hyperintensity around the right anterior aspect of the sylvian fissure. They usually don't have evidence of enhancement, and there's usually increased diffusivity. And then within the left cerebellum of another child, these little clusters of T2 prolongation are evidence of the multinodular and vacuolating neuronal tumor, which is a don't touch lesion because they don't grow and they tend to just be found, but not significant in terms of progression or morbidity. Now let's talk about the ependymal tumors. And these are grouped now with the 2021 WHO classification according to the anatomic site and the molecular subgroup. So they're grouped as if they're supratentorial, posterior fossa, or spinal cord. And then there are 9 molecular defined subgroups that are defined by the gene, the DNA methylation profiling, and they differ in location, age, and prognosis. So first, let's talk about the supratentorial ependymomas. The majority of these are the ZAFTA-REAL effusion positive ependymomas. They're often seen in adults and children, and they're often extraventricular. Then there is the YAP1 fusion positive ependymoma, which is actually extraventricular as well in the hemisphere. That's less common. And then there's some that they can't characterize, about 10%. So here's an example of the ZAFTA-REAL effusion ependymoma that was determined molecularly. And here this child was 16 years old, had this lesion within the posterior thalamus. Associated with that lesion, there was some nodularity around the margins of it. And you can see that nodularity showed some reduced diffusivity, reflecting increased cellularity in that regions of nodularity, and there is evidence of enhancement within these areas of reduced diffusivity, as we can see on the axiochronal images. Now, the posterior fossa ependymomas, these are characterized by, if it's an adult, subependymoma, and then the posterior fossa ependymomas are in two subgroups, the PFA and PFB, that differ in age and prognosis. In infants, you mostly see the PFA, and in older children and adults, you see the PFB. Here's an example of a child, 14 months old, who has the classic ependymoma, as we are known about in the posterior fossa, but it's the PFA. And we can see there's marked hydrocephalus. We see this lesion. It's in the fourth ventricle. It's going out of Magendie and Luschka. It has heterogeneous signal. It has some areas of reduced diffusivity, but it's often more heterogeneous in terms of reduced diffusivity within the posterior fossa. And then there's little or no enhancement, but it's really quite involved, extending into the pontine cistern as well. Now, what about the spinal cord ependymomas? Now, these are classified by myxopapillary ependymoma, subependymoma, which is very rare, the classic ependymoma, and then a particular spinal ependymoma that's new, the MYC amplified, which has a very poor outcome. And so we'll look at some of these. Here's a child who presented with back pain and had this unfortunate mass within the spinal canal. We can see on the sagittal T1 and T2 weighted images that on the T2 weighted images, there are areas of hypointensity within this lesion. And then after contrast was given, we can see very intense enhancement with also present leptomeningeal enhancement along the surface of the conus. Now, different in this WHO classification of 2021, it used to be that these were thought to be WHO grade 1 lesions, but now they're WHO grade 2. Here's another child who's an 11-year-old boy presented with neck stiffness and a limited range of motion. And we can see this kyphosis that's developed because there's a very large spinal canal and spinal cord tumor expanding the spinal canal and having areas of T2 hypointensity, which we see with these spinal cord ependymomas, reflecting some areas of hemorrhage within it. And then there's some areas of enhancement after contrast is given. So this is pretty classic for the spinal cord ependymoma. Now let's move on and talk about pediatric high-grade gliomas. And these are now characterized into various categories, and they're based actually on the molecular profiling. They include diffuse midline glioma, the hemispheric glioma, high-grade pediatric tumors, and then the infant type hemispheric glioma. And we'll go over some examples of this now. So first, just to understand that these high-grade tumors in children can occur in many locations, and depending on where they occur, they are associated with particular survival. So the lesions that are high-grade within the hemisphere have a much better prognosis. All of them have a poor prognosis, but a little bit better prognosis than those that occur within the brainstem. And then if you look at the mutations that are involved with these high-grade tumors, depending on your mutation type, in particular the histone mutations, if you have the histone altered mutation involving K27M, then those have a much worse survival. So we'll look at some examples. So first, let's talk about diffuse midline glioma. And as I mentioned, this is an infiltrative midline glioma. There are somatic mutations of the histone genes, and it's related to substitutions of lysine for methionine in one of the histone tails. And about 80% of pontine diffuse midline gliomas harbor this mutation. They're very high grade, and the ones in the brainstem have a very poor prognosis. And even today, in 2023, the 2-year survival, despite all therapies, is less than 10%. So it's an area of significant research and many therapies to try to see if there can be a treatment for these unfortunate children. The diffuse midline glioma can occur within the thalamus, the cervical spinal cord, and the brainstem. And when they occur within the thalamus, they can present like this child did with frequent headaches and seizures. And one can see that this patient had, hyperintensity within the thalami bilaterally. you can see that the diffusivity is not particularly reduced. However, on the ASL images, we can see that there's increased perfusion within these areas of signal abnormality and very little enhancement. And this is an example where enhancement really cannot really tell you about the grade in children, because this is a high-grade tumor, H3K27 altered, and yet there's no disruption of the blood-brain barrier. Similarly, these can occur within the pons. Here's another child presented with the classic features with a brainstem lesion with multiple cranial nerve palsies. The brainstem is actually expanded. We can see that it's expanded and surrounds the basilar artery, extends into the middle cerebellar peduncle, and there can sometimes, usually there's homogeneously bright signal within these tumors, but occasionally there can be heterogeneous signal. And in those areas where there's dark signal, often those areas will enhance and have reduced diffusivity and increased perfusion. So there is some heterogeneity that can occur within these tumors. And if so, if these features are present, those patients that have areas of reduced diffusivity, areas of enhancement, and areas of increased perfusion that are the diffuse midline glioma actually have a shorter survival. Now, why do these occur? Well, it's thought that there's the oligopontine precursor cell that's involved with the cell that's PDGFR alpha that leads to the normal differentiation of the glial cells. However, if there is a mutation, such as this histone mutation, there's a deregulation of that pathway, and it leads to additional dysregulations that people are trying to understand to the diffuse intrinsic pontine glioma. Now, it's thought that from research that's done that this particular mutation likely occurs at some point as the child is developing, perhaps within the stem cell of the embryo. And as the oligodendrocyte maturation occurs, of course, these gliomas can occur. Here you can see the normal development of the oligopontine oligodendrocyte precursor cell when you have the normal development compared to if there is that mutation present. Then there will be the development of these glioma-like cells and differentiation in this capacity. And this is work that's been done by these authors who do a lot of research in this domain. So there have been various clinical trials to look and try to treat these children, and I'll just share with you one that we were involved where we tried to see if there were metrics that were associated with survival, imaging metrics in patients who had newly diagnosed tumors. And so the patients were in this particular study, and they were given a drug with radiation followed by maintaining it with another drug, ABT888 and temozolomide. And as secondary objectives, perfusion, diffusion, were used to actually determine if there were ways to correlate with disease outcome. And also the drug that was associated with pseudoprogression. And so just to see if any of these metrics would be able to actually differentiate that. And what we found with this drug, which is a anti-cancer drug that is a PARP inhibitor, is that that patients that had a shorter survival were those that had a rapid increase in terms of their regional cerebral blood volume on dynamic contrast susceptibility imaging, as well as increase in some of the metrics on T1 permeability as well. Now, in terms of this particular group, as I mentioned, the drug could actually cause a certain situation where it looks like the tumor is progressing, but the tumor is really not. It's just an effect of the therapy. And so we actually looked at that volumetric assessment of the ADC values and found that those patients that actually had early progression had a marked decrease in terms of their ADC values within the tumor over time compared to those that had pseudoprogression. And so there's many attempts now to try to see, can we determine how to distinguish progression and pseudoprogression, because often the patient will be on the therapy. You don't want to take them off the therapy if it's helping, and you don't want to mistake it for progression if it's pseudoprogression. So it's a really hard issue, and it's being dealt with both in adult and pediatric clinical trials. Similarly, we actually looked at imaging correlates to try to see, is there anything in our imaging that correlates with the molecular and mutational analyses of children who have diffuse intrinsic pontine glioma. And these were children who had biopsies of their tumors very safely. And then we looked at the standard values, the standard features of these tumors, as well as the diffusion values within these, and tried to correlate them with the histone mutations. So as I mentioned, these histone mutations are involved with these diffuse intrinsic pontine glioma, and there are subsets of these that have differences in terms of survival. So in terms of looking at those, we looked at one of the mutation types and compared it with the other. And in the one mutation type where the survival is shorter, those patients tend to have lower ADC values within their tumors, perhaps reflecting increased cellularity compared to those with a longer survival that have increased diffusion values within the volume of the tumor. We're continuing to look into this in terms of pooling some data to determine if there are further metrics. And this is an area that's really ripe for radiomics, because certainly there may be features that are in the standard imaging that we can't really see with the human eye, that AI or artificial intelligence might be able to help us with. We also have looked at diffuse intrinsic pontine gliomas and tried to correlate them with features you see with PET. So some of these tumors in the brainstem will have increased uptake, like you see here. Here's a tumor within the brainstem, very hot on the PET scan, compared to a different child who has this tumor and the uptake's not as high. And so we looked at the diffusion values and tried to correlate them with the PET. And what you find is in those patients that have an inverse relationship between the uptake of the PET and the diffusion values, these patients have a much shorter survival than those that don't have that association with a flatter curve, and that progression-free survival is 300, like a longer interval, and that was statistically significant. And I bring this up just to say that we can take our imaging techniques and combine them to try to see if we can determine if there are other metrics that we can evaluate for survival. Now, in terms of the pediatric types tumors, in the new WHO classification, glioblastoma is no longer a term that's used. And so it's really not a term. It is still used in the adult classification, but not in the pediatric. Now, this is a new of the types, which is called the infant type hemispheric glioma. And this was a child who presented with this very large mass as an infant. You can see on the FLAIR and T2 weighted images, it's extremely dark. There's marked enhancement. There's also evidence of a lot of vascularity within this tumor on prominent vessels and a markedly reduced diffusivity with enhancement. And this is an infant, a newborn infant who had this. And when they looked at the molecular pathology of this, they found that this is one of these new characterizations, which is called the infant hemispheric glioma. And in this particular patient, they had one which was called ALK rearranged, or WHO grade 4. And so basically, they've taken these tumors that are in newborns and infants. They look at the molecular profile and the fusion genes, and they usually fall into 4 categories, which is either ALK, ROS1, the NTRK, or MET. And so it's something that they're looking at. In this case, the H&E showed necrosis, positive GFAP, and then the molecular test demonstrated that there was positivity for the ALK, which helped to make this diagnosis. Now let's move on to the embryonal tumors. And these are a large group of tumors, and we'll talk about some of them in the next minutes ahead. One of the most common in this group is medulloblastoma. It represents 63% of all embryonal tumors. And it's important to remember that medulloblastoma can occur just as a de novo phenomenon. However, there are hereditary cancer predisposition syndromes that are associated with these developing, such as the Turcotte syndrome, Gorlin syndrome, Leptomeningeal, and Curry-Jones syndrome. These each individually have unique mutations, and it's really unclear why the medulloblastoma is involved, but those pathways must have an influence in terms of the development of these medulloblastoma subtypes. Now, in the 2021 categorization, they are mostly molecularly defined, and some are histologically defined. And it was originally thought that there were just 4 simple subgroups of these tumors, but it's been recently reported in the last few years that not only are there 4 molecular subgroups, but within each subgroup, there are several subgroups. So, for example, there is the Wnt sonic hedgehog group 3 and group 4, and within these molecular subgroups, for example, sonic hedgehog, there are 4 different types, and in the group 3 and group 4, there are several different types. So what this shows you is as our knowledge improves, in terms of this molecular characterization, we find that it's much more complex than actually the human mind can actually perceive. And it's probably even more complex than the most recent categorization. And that's really the challenge in terms of treating these children and understanding cancer in general. So in 2014, it was discovered that there could be some MR surrogates for the molecular subgroups, with the Wnt being often seen in the middle cerebellar peduncle, with the sonic hedgehog in the cerebellar hemisphere, and the group 3 and group 4 tend to be in the midline. The group 3 often has enhancement, the group 4 doesn't. And then this was something that's reported. It doesn't always follow this pattern, but these are characteristics that you could use to perhaps look at some of the molecular groups. Recently, in Nature, and this fall, it was discovered that the group 3 and group 4 medulloblastomas come from a specific developmental part of the rhomboglip subventricular zone. This is the normal development of the cerebellum that occurs after certain post-conceptual weeks. And in this little region here, they found that it's because of an aberration that occurs within this rhomboglip subventricular zone that these tumors develop, the group 3 and the group 4. These patients often present with a fourth ventricular mass with reduced diffusivity and enhancement. As I mentioned, there can be actually different imaging presentations based on the molecular subgroup, but this is the classic configuration in a child who presented with vomiting and altered gait. Now, this is the most common of the seeding tumors, so it's very important to screen the entire neural axis, as in this patient with medulloblastoma who has significant metastases both in the suprasellar region, the periaqueductal, and then studying the lateral ventricles bilaterally. And it's thought that actually what happens is that these tumors, either through CSF dissemination or hematogenous spread, shed, and that there are these sort of clones that go to the area either within the CSF or along the hematogenous spread, and that leads to genetic differentiation and divergence in the leptomeningeals. And there's a bunch of processes that are associated with this involving the immune system and neovascularization. Now, as we speak about these molecular subgroups, there have been people that have tried to say if you have this molecular subgroup in medulloblastoma, are there characteristics in the seeding patterns? And indeed, it's been found and described that, for example, in the group 3, it's more often laminar or superficial linear enhancement along the surface of the brain and spine, with very large sized metastases if it's a very small tumor. And in the group 4 tumors, suprasellar metastases were thought to be specific. And in group 4, as you remember, that's the one that doesn't enhance. So it's really important to often add diffusion imaging to actually discover where the tumor seeding is. The sonic hedgehog group tends to occur around the cerebellar resection cavity. Now, some of the problems that can happen is if you just go ahead and image these children with contrast afterwards, is that if they're a non-enhancing tumor, you might not see the seeding. So here's an example of a patient on the T1 weighted images where it's really hard to see that nodule because it's not enhancing. And even if you do two weighted images, you might be able to see it a little bit better, but it's really with either Fiesta or space images. These are high resolution T2 weighted images that you can see the nodularity. In addition, it's also important to realize that diffusion imaging of the spine can be very helpful. And in this case, this is a patient who had non-enhancing foci, very difficult to see post-contrast, but we see with the diffusion, we can see that these little nodules of enhancement have reduced diffusivity on both the trace and the ADC map. Now, this is important because you immediately have to make sure you know what the extent of disease is for these children, because even though they do get cranial spinal radiation, there may be additional therapies that need to be added on to actually improve their survival. And if we misdiagnose the disease, this really, they are starting at a very poor vantage point. So it's very important to see if you can see these with the T2 or the diffusion. And also, if you're screening these children, it's also important to do the screening of the entire cranial spinal axis prior to surgery, if you can, because otherwise you run into this problem. So sometimes these children come in with these tumors and they have to be rushed to the OR, either because they're having herniation or there's severe hydrocephalus. In most cases, we're able to actually screen the whole cranial spinal axis. But if you have a situation where this cannot occur, you run into this problem where on the sagittal T1 weighted images, you can see these large subdural collections. And obviously, you can see that these subdural collections that are space occupying will really impede your detection of drop metastases. So if you do encounter this, that you have them, you either have to follow these patients up after 2 or 3 weeks, or if you have diffusion capabilities along the spine, you can do diffusion weighted imaging, and you can see here that we do not see any reduced diffusivity to suggest that there are metastases. Okay, so that's medulloblastoma. Another big embryonal tumor are the ATRT tumors. These are the most common malignant CNS tumors in children who are infants, and they have a unique mutation involving chromosome 22. And the molecular subgroups actually include ATRT tyrosine, ATRT sonic hedgehog, and ATRT MYC. And you can see, according to this paper in 2020, that these have unique ages and gender distribution, unique tumor location. For example, ATRT can sometimes occur within the spine, and the molecular subgroup that's usually associated with that is the ATRT MYC, and you can see that represents like 12% of those. And they have unique aberrations in terms of the oncogenic pathways and transcriptional features. So some people have actually been looking at these, and indeed in one article published in 2021, they found that in the subgroup of children, infants that had non-metastatic disease, the tyrosine group had a much more superior overall survival, whereas the ATRT sonic hedgehog group is often associated with metastatic disease and a poor outcome. Now, there have been some people that have looked at MR spectroscopy, and in particular to try to see if there are differences in terms of the metabolic profiles of these children. And it ends up that there's a energy metabolite that's really synthesized in the kidneys, the pancreas, and liver, which is creatine. And this is taken up by the bloodstream, and it's expressed in oligodendrocytes and neurons. So they've actually looked at these investigators, Dr. Temrazi and others, looked at supratentorial, and they found that they could actually distinguish those with this expression compared to those by the basis or the presence of creatine. And if this creatine is present, they have a better overall survival. Now, another of the embryonal tumors are the embryonal tumors with multi-layered rosettes, and these are a unique molecular profile as well. They're usually seen in young children in the first 2 years of life, and they can be supratentorial or infratentorial. Now, they have really unique imaging features because they tend to be very large, with big areas of calcification, but there's no surrounding edema and very little in terms of contrast enhancement. They do have reduced diffusivity and a poor prognosis, but these are features that are unique to the embryonal tumors that have the multi-layered rosettes. Here's an example of one that a patient had. His child had this very large mass within the frontal lobe. You can see chunks of calcification within it. There were small blue cells and neuropil on the H&E stain. And we can see that even though this is a very large tumor, there's little or no surrounding edema. There is reduced diffusivity because these are high-grade tumors that have increased cellularity, but there's little or no enhancement. And so this is really typical for the embryonal tumors, this ETMR. There's also a subset of these called the ETMR Dicer 1. And this Dicer 1 syndrome is caused by mutations in a gene called Dicer 1. And this gene is associated with microRNA. And just to say that if you have the aberration of this, these patients can have an increased incidence of tumors. And here is a child who had developmental regression and strabismus, had this very large posterior fossa mass. We can see it on the T2-weighted images, has areas of hyperintensity and then reduced diffusivity. There's increased permeability within this lesion, and of course, elevation in the choline peak, and then heterogeneous enhancement in this child with embryonal tumor with Dicer 1. Similarly, there's another type of tumor, the CNS tumor with B-core internal tandem duplication. And this patient was an example of one who had this within the thalamus, causing significant hydrocephalus and reduced diffusivity with little or no enhancement. Now, it's important to remember that as we learn about these genomics and we have all this imaging data, that there is really a link that we have with radiogenomics. And linking genomics and imaging data is really important for us to determine the characteristics of these tumors as well. And one example, and this often will require multi-center approaches where we pool data together, collaborating from different institutions throughout the United States and the world to try to see if we can determine if these techniques can help. So this was an example of a particular study where deep learning was used in children who had posterior fossa tumors. There were 600 children from 5 pediatric institutions, and the machine learning model was able to actually detect the posterior fossa tumor type with an accuracy that exceeded an area under the ROC curve was 0.99 and was similar to 4 radiologists. The accuracy was easiest or best with diffuse midline glioma, and ependymoma was not as good in terms of the model accuracy. But these are some of the applications that are going to be done as we move forward with radiogenomic analyses and the utility of artificial intelligence in this domain. Similarly, last year, this article was reported, which we participated from Kristen Young's group, and this was looking at MR radiogenomics of pediatric medulloblastoma, and an MR-based machine learning model was designed, and it was able to actually differentiate the 4 unique medulloblastoma molecular subgroups and really reliably uncover quantitative features within some of these subgroups that the human eye could not really see, which is very interesting and also exciting. So in summary, I've tried to give you an overview of some of the imaging and molecular features of a subset of pediatric brain tumors. It's been really an honor, as I mentioned, to share this work with you, and especially to be able to speak today for the Health for the World program, which is a wonderful, wonderful program that's really helping us to share our knowledge across the world. So thank you so much for the invitation.
Thank you so much, Tina. This was an excellent grand rounds. You did such a great job simplifying such a complicated topic, and I'm sure the audience really loved it. Let me see. I think the questions, if everybody has questions, please feel free to enter in the Q&A box. In the meantime, there are some questions which we can address right now. Tina, you talked about the new category of polymorphous low-grade neuroepithelial tumor of the young. And, I know it's very challenging to distinguish from oligodendroglioma, given it's cystic and the calcifications. From imaging perspective, is there any way, you can favor, polymorphous low-grade neuroepithelial tumor? I know pathologically there are neuronal markers, but it's always very challenging to distinguish them.
Yes, I think that oligodendroglioma is actually not as common in children, and we do see those lesions in the temporal lobe in particular, but not as common. So it's just something to consider, in particular when you see those imaging features. That might be a possibility, specifically if there's calcification and if it looks sort of like an indolent lesion, that is, there's not as much surrounding edema, the T2 hyperintensity is not as extensive, and it has the calcium. But it is challenging because some of those, the example I showed, actually did show that that was in the temporal lobe. So I think you would have to actually include oligo in the differential diagnosis, but understand that there are other entities in that low-grade spectrum.
Right, right. And I was so glad you mentioned all the artificial intelligence, data, and I really like your study on the quantitative ADC, for distinguishing pseudoprogression of diffuse intrinsic pontine glioma. And as far as AI tools, have you used any AI tools for, quantitative ADC assessment in diffuse intrinsic pontine glioma,
No, but it's something that, we're interested in pursuing. Right now, it's kind of like a manual, sort of time-intensive process done by one of our research scientists who's done a really great job. But that's actually an example of something that, if automated, would be really a wonderful thing, because not only could it be applied to pediatric brain tumors, but also to tumors elsewhere in a sort of automated, in other parts of the body in an automated way. So I think that that's kind of one of the rate limiting steps for that technique, that really it's still not something that you can actually just take. There are some software actually that are trying to work on automating this. There are some proprietary software that I'm aware of that does have the ADC histogram, but you have the challenge if the values or the analysis that one set of investigators does, is it actually the same result that you're going to get from another set of investigators? So this is really a big challenge in terms of some of the advanced techniques and analyses, the reproducibility, and also making sure that we have ways to actually have uniformity in terms of our approach and standardization in terms of some of these tools. And what you find is that cross vendors, there can be quite big differences in terms of this. And this makes it extremely challenging in terms of some of these analyses. In the past, we were involved in a project where we looked across vendors at the assessment of diffusion values, in particular, sort of as a phantom, to see, is the diffusion value on vendor X the same as diffusion value on vendor Y? And this is so important for the kind of work that you would do in studying these techniques and making sure that my colleague at X university gets the similar results. And so fortunately, there was some agreement in terms of some of those values within a certain percentage, but it's really important, like less than 5%. But it's really important that involves standardization of protocols, techniques, and things that will incorporate variables if they're not standardized. So I think that's sort of our challenge. Fortunately, with the AI different institutions can pool, data sets, etc. But and actually come up with some great conclusions. But I think one of the challenges we have in imaging is to make sure that that we have standardization of our processes such that we make the correct
Yeah,
conclusion.
I completely agree. And what I like about your study is that you used ADC quantification, which is widely available around the world. Diffusion is, some of the other imaging modalities like perfusion and MR spectroscopy are not available in some of the countries where we work. So I think
Right. I think diffusions are very important, and it's a very fast sequence. And it can give you a lot of information in many, many disease states. Of course, the most popular being stroke, but with the tumors, of course, it can give you further characterization of the values, and of course, just the cellularity within the tumor, which may correlate with tumor grade, but there are other applications as well. The diffusion is really good for it.
Right. So I think we are getting close to 8, so we'll wind up, but we have some excellent comments here. We have Dr. Sulu Saidu saying, thank you, Dr. Poussaint. Glad I'm able to join. Dr. Enrique Menero from Mexico says, excellent lecture. Congratulations.
Thank
Dr.
you.
I'll just
I
read.
appreciate them taking the time out of their busy schedules to listen, and
Yeah.
I also greatly appreciate this resource that really serves to share knowledge, across the globe, which is so important. As we share knowledge, they have knowledge. People have knowledge at other places to share with us, and we have knowledge to share with them. And it's really by sharing our knowledge in terms of access, teaching, etc., that we really are going to be able to actually improve healthcare throughout the world.
Thanks so much for doing this. We have people, so in Africa, it's like evening, Latin America, late afternoon, and in Asia, it's late night. So
Oh my goodness.
we have people from Philippines and other places who are joining in late night because they were so excited for your talk. And
Oh, I appreciate them doing that. That's really something.
yes, and then I'll just read one or two nice comments and then we can finish it. We have Dr. Londiwia Bibiala says, great presentation from Limpopo, South Africa. Dr. Iona Grossman says, thank you from Brazil. Dr. Sam Neguno, amazing lecture, thanks a lot. We have Dr. Yeliz from Turkey who has joined. They are just going through the earthquake in Turkey, so I hope everybody in Turkey is doing okay, but she still joined. She was very excited for your talk.
Oh my goodness, that's really phenomenal.
Thank
And
you.
our hearts are with you. Our hearts and prayers.
Thoughts and prayers are with you. I hope you and your family stay safe. Thank you so much, Tina. This was a wonderful talk.
Oh, it was so nice to be with you today. And so
Absolutely.
hope to do so again in the near future. So
Absolutely. Thank you so much. We really
thank
appreciate
you.
it. Thank you.
Thank you. Have a great day.
You too. Bye-bye.
Bye.
Bye.